You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. And I want to thank all of you for joining us on this episode. Today we're going to be discussing ALL, acute lymphoblastic leukemia, including frontline and relapse treatments, the role of MRD, emerging therapies, transplant considerations, and strategies for managing side effects, as well as supportive care. We're delighted to be joined by Dr. Catherine Lai, who's an associate professor and the physician leader of the Leukemia Clinical Research Unit at the University of Pennsylvania's Perelman Center for Advanced Medicine. Catherine, thanks for joining us.
Yeah, thanks, Dr. Miller. Thanks for having me, and thank you to LLS. This is a great opportunity.
And for all of us at LLS, too, to have you. So it's mutual. When we're fellows in oncology, there's a lot of stuff we're exposed to, or for that matter, residents, et cetera. How did you end up in the leukemia field, and also why a particular interest in ALL?
Yeah, I love this question.
Good.
So I went into medical school thinking I would do rheumatology because I have an aunt who had juvenile RA and had multiple joint replace, but really got interested in malignant hematology in third year of medical school. And that's because I was assigned to an inpatient medicine service, but they also had our malignant heme patients. And I just really fell in love with the patients and the pathophysiology and the science behind the disease. But it was also really hard. As you know, those patients are very sick. Most of them don't do well. And so I really struggled with that. And it was the oncology fellow that said, come to clinic. When you're done with inpatient, come to clinic. It's a whole different situation. And I did. And it was. You see the patients dressed in their normal clothes. They're the ones in remission. They're doing well. And so that's what started my interest in malignant heme. And then just at every opportunity that I was able to do some research in it, did that. And then when I did fellowship, this was at the NCI, I actually went in thinking that I was going to do allotransplant. I like taking care of sick patients. The science also, the immunology behind allotransplant is also very interesting. And when I got there, the clinical mentor that I was supposed to have had left. He had gone to another institution and he's doing very well. And I still know him very well. But interestingly, I did all of my fellowship training in clinical trials in aggressive lymphomas, because that was a busy service and that was the opportunity that was afforded at the time. And as an NCI fellow, we are able to rotate through Hopkins to do the acute leukemia service there. And so I did, and I was fortunate enough to work with Dr. Judy Karp in her second to last rotation as an attending before she retired. And just everything about acute leukemias clicked. And she's still a mentor. I still talk with her on a regular basis. And so that was when that transition happened. And so I'd say it's the combination of putting in hard work combined with serendipity in terms of you never know what situation you might be put in that would lead to an opportunity. So then I switched and I applied all my knowledge from clinical trials in aggressive lymphomas to acute leukemias. And so here I am.
And there you are. And actually, what we're talking about today is a lymphoproliferative disorder. So,
Right, yes.
Any patient in particular you remember from way back that actually had an influence?
Oh, that's a good question. I don't think it's any one particular patient. I think it's the combination of the spirit of all of the patients and being able to take them through their patient journey, irrespective of age. I think it's having that conversation with the patient about what their goals are and then being able to come up with a treatment plan that helps them meet that goal.
Yeah. So thank you. And I have to say, because these are things that I think about, so it's fun to talk about them, and we don't have a chance very often.
Yeah, definitely.
So, by the way, I went to Hopkins, my fellowship, because of Judy Karp.
Oh, yes. Her legacy is, yes, she has, her mentees are scattered across the country.
I'd like to start out by talking about ALL in adults. Obviously, there's been so much progress and exciting news over the decades in childhood ALL, but I'd love to get your sort of 60,000-foot view of ALL in adults. Where are we at in terms of progress compared to, let's say, 20 years ago, 10 years ago, now, perhaps in the context of childhood ALL?
Yeah, that's a great question to start us off, Dr. Miller. So I'll give just a brief background just to put everybody on the same page. So in the United States per year, there are about 6,000 cases of ALL in total. Now that takes into consideration both kids and adults. And so as you mentioned, the majority of those are children. And so it's really a rare acute leukemia. And so overall, these patients should be treated at academic institutions that see a lot of acute leukemia patients. When we talk about presentation, it's typically patients with a high white count, but then also have an anemia and thrombocytopenia. And as a result of that, you have symptoms of fatigue or of bruising from the cytopenias that they do have. In terms of treatment, though, getting to your main question, in general, the treatment has been revolutionized really by the combination of immunotherapy with chemotherapy. And I'm sure we'll get into how do we sequence our therapies to maximize the benefit while minimizing the toxicity for patients. I think it's really changed. When I first started training, we really only had chemotherapy. And as it's evolved over the last decade or so, we've seen an explosion of drugs. And initially, it's just the combination of chemo and immunotherapy. And now sometimes it's just immunotherapy alone. So it's been great for patient outcomes.
Tell us a little bit about the subtypes.
Okay, so let's take a step back first because we have to subtype the patient and what type of ALL they have. So, how I think of it is we have two big categories in terms of B cell ALL versus T cell ALL. And in general, the patients with T cell ALL tend to do worse. And then among B cell ALL, we then subdivide again into those patients who are pH positive and pH negative. And so once we have the diagnosis, we then look at what a patient is willing to tolerate in terms of fitness for chemotherapy. And historically, we have certain age cutoffs, although I think that line is becoming more blurry. And so we then put patients into three baskets based on their age or approximate, I'll call it physiologic age. So less than 40, we consider our adolescent young adult patient population. 40 to 50, we tend to still treat these patients somewhat aggressively if they're able to tolerate. So we tend to give them pediatric inspired protocols. And for those less than 40, we definitely give them our pediatric based regimens, which I'll get into. And then over 50 is where it's really changed in the sense of giving a modified version of a chemotherapy with an immunotherapy. So that's big picture. If we get into your more specific question about how that's changed, I would say the other big thing that has changed is the addition of TKIs for specifically for that Philly positive group of patients, Philly positive B cell LAL patients. That has improved the outcomes in patients. And there's a big debate, especially depending on the response and if patients have a good response, in terms of whether or not those patients should even be going to an allogeneic bone marrow transplant or not.
Let's actually look at the subpopulations of adult ALL. For example, patients that are Philadelphia chromosome positive, what's the prognosis for that group and what's the treatment approach?
Yeah, so for the Philadelphia positive B cell ALL patients, again, we separate them into quote unquote younger and older. And really, it's whether or not somebody is able to tolerate a hyper CVAD based backbone, so more intensive chemotherapy. And then we also add a tyrosine kinase inhibitor or TKI. For those patients who are older, then we tend to also give them the TKI backbone, but you can just do TKI and steroids alone for some period of time until they get into remission, and then it's followed by blinatumomab. And so from that standpoint, that's where that immunotherapy comes in for our older patients. What's interesting is the two things that I talked about are kind of what's standard of care. There is a very interesting clinical trial that's being done in the cooperative groups as a part of ECOG that is looking at all patients who are Ph positive with B-cell ALL, irrespective of age, and they're randomizing them 1-to-1 to that chemotherapy plus TKI versus immunotherapy with blinatumomab plus TKI. And so I think that is very interesting because that will tell us whether or not we can use our immunotherapy in our younger patients. I think historically we just think that we know that younger patients can tolerate chemotherapy and that's what's always been done, so that's what they should get. But now with these newer therapies, we might be able to actually have similar efficacy, if maybe even better, without the toxicity of our traditional chemotherapy.
To be terrific. How about T-cell ALL? Let's talk about that subtype, which is particularly problematic in terms of outcomes. It has been in the past, and I think is still.
Yeah. With T-cell L, I think it's more challenging because I don't think there's a certain standard of care per se. I think it's really dependent on the institution you're at and what you're familiar with. I would say for the younger patients that we define as less than 50, we try to use a pediatric inspired regimen. So that's including asparaginase. And usually, if they're on the older side, maybe over 40, the asparaginase is given later as opposed to earlier. And then there are some regimens that also will include nelarabine. We know nelarabine is one of the drugs that's active in T-cell ALL. And so then they're getting that incorporated. And then, depending on their response, determines whether or not they can just continue the chemotherapy with the induction consolidation and onto the maintenance phase, or whether or not they need a transplant. And so we're really looking to MRD to help us determine which patients need to go to transplant. Now, in patients who are over 50, we use less intensive chemotherapy, no asparaginase. Mini CVD is often a common backbone, and there's some interesting data looking at the addition of venetoclax with that mini CVD to help our T-cell ALL patients, especially the older ones.
By the way, it's interesting where venetoclax pops up.
Yes, yeah. Has multiple uses.
It really is. And then finally, with B-cell ALL, I'd love to get your perspective on age also, but how do you make the decisions in that group?
Yeah, so for specifically, you're referring to the Ph negative B-cell
Yes,
ALL
correct.
patients?
Yeah.
Correct. So then again, for the younger patients, so definitely less than 40, we're focusing on a pediatric inspired regimen. Again, depending on the institution, I think there's a few different major pediatric inspired regimens that can be used. So asparaginase that's been given early on. What's been practice changing has been the incorporation of blinatumomab for all patients who are Ph negative into the regimen into consolidation. So this is something that was recently FDA approved, and the results showed that whether or not these patients were MRD positive or negative after the first phase of chemotherapy, when they got randomized to blinatumomab or not, even the patients who were MRD negative still had an improvement in relapse and overall survival. And so this shows us that all patients who are in this category of Ph negative B-cell ALL should get incorporation of blinatumomab into their consolidation chemotherapy at some point. So that's across the board for all patients. That study was mostly done in younger patients. And so we typically, for those patients who have that pediatric inspired regimen, that specific study was E1910, which was an ECOG cooperative group study. That's primarily what we're doing. For the 40 to 50 age range, we're still using that pediatric inspired regimen, but the asparaginase is given at a later time point as opposed to earlier in the first week of therapy, and then still adding the blinatumomab. And then for the patients who are older, say who aren't able to tolerate asparaginase, the backbone is mini CVD, and then the addition of blinatumomab.
Let me ask you, because blinatumomab is not used often, at least in community practice, or used less often. What's the mechanism of action, and what are the toxicities, and what supportive care do patients need?
So blinatumomab is a bispecific antibody, and so it means that the two targets that are on it, it's a CD3, which engages the immune system, and then the other end is a CD19, which is specific to patients who have lymphoid malignancies, but in this case, we use it in our ALL patients to then go and harness the immune system to then attack all those cells that have CD19. And so the side effects that we see from it are typically the majority of the time in the very beginning. So these patients are admitted to the hospital to watch for something called cytokine release syndrome, which is an overwhelming inflammatory syndrome that can be fever, it can be hypotension, tachycardia. And so it can be neurotoxicity, and it typically resolves by holding the blinatumomab and giving steroids. And then typically you can resume it, and the majority of patients do well. And so once they've passed that 48-hour to 72-hour window, it is then typically safe for them to leave the hospital and then continue this infusion 24/7 for 28 days in a row total. And then they get 2 weeks off. And it's a little bit cumbersome in the beginning because you have to learn logistically how to handle the backpack and how to change the blina. But once they do it, it's very straightforward. And so, what I would say is because blinatumomab has shown to be so effective in a lot of our therapies, that I think we will see more use of it in the community. And it's something that the toxicity, because a lot of it is early on, it's going to happen in the hospital. But once they're outpatient, they really do okay. The questions more come from oh, my pump is beeping or something got disconnected. How do I handle it? So it's really then just needing the support staff to be able to be available to triage those questions.
So you bring up a really important point, and just in cancer in general, which is the role of the immune system, or the lack of the role of the immune system. Because people say, why isn't my immune system killing this cancer? And I describe it in very broad terms that cancer is often able to hide from the immune system. In the case of ALL, what are some of the mechanisms by which, again, our own immune system is not effective? And taking it a step further, because you opened up the door with blinatumomab, what other immune therapies are present now, and what else is on the horizon?
Yeah, so that's a fantastic question. So the other agent that is approved for relapsed ALL, actually there's two, so I'll start with the first one that I'm thinking, is inotuzumab, which is an anti-CD22 antibody drug conjugate. So it was approved as a single agent. We also use it in combination as a backbone with mini CVD. Again, this is for the B cell ALL patients only, not for the T cell ALL patients. And I would say we used, or at least I used, more inotuzumab actually during COVID, because blinatumomab you have to be admitted at least for the first 48 to 72 hours, but inotuzumab is just given weekly, and so it was very easy as an outpatient. What I would say is a single agent in the relapse setting, it works, but people typically relapse after 6 months. And so really it's needing the combination of a chemotherapy with the inotuzumab when you're using it when you can, prolongs the duration of response and also improves the CR rates. The other really exciting therapy that uses immune therapy is CAR T cell therapies. And there's a handful of different CAR T cell therapies that have been approved on the market. And so from that standpoint, that has also really revolutionized how we treat our B cell ALL patients. And more specifically, it tends to be our Philadelphia negative B cell ALL patients.
So what's the relationship between, for example, blinatumomab being effective and CAR T being effective? How are the mechanisms of action different? Is one building on the other? I'm trying to understand that better.
Yeah, so they both have the same target. The CAR T cells products also target CD19. And so it gets tricky. That's a really good question because it's a good thought in terms of sequencing. How do you sequence two products that have the same target? So I think of it more in terms of when a patient needs as opposed to kind of doing sequencing back to back.
Got it.
So blinatumomab, because it's a bispecific antibody, it's something that is manufactured that is irrespective of the patient's immune system. Whereas the CAR T cells and the CAR T cell products are manufactured in a way, so I'll take you through the process. And so that you actually take a patient's own immune systems out, and then you are essentially engaging them. So you're putting them on steroids to then engineering them in a way so that when reinfused, they're then able to specifically attack their own cells that are labeled with that CD19. And so after a patient's cells are removed, they also receive a lymphodepleting therapy to dampen down their own immune system so that when the CAR T cell product is infused, it focuses on killing the leukemia cells and not any of its own immune cells. So you also have cytokine release or CRS with CAR T cells, and it can be much more extreme compared to our blinatumomab. But the efficacy of CAR T cells is also very high, similar to our blinatumomab. And so what I would say is until recently, the products were more focused on younger pediatric patients, but more recently, there have been CAR T cell products that have been very effective in adults and have changed in the sense that they have been able to overcome toxicity. And specifically, the most recent approval, Obacel, has a dose fractionation. And so it's a split based dosing. You're still getting the response rates, but you're minimizing the toxicity by having that split dosing.
Take us through a patient's course. And let's say, unfortunately, this would be an adult. I'm going to throw out the age 50, but, a 40 to 50-year-old healthy who unfortunately gets different lines of treatment and fails. And I'd be interested in, again, your thinking about what do you start with? What happens next? What happens next? What happens next? Because there's so many things available, including blinatumomab, CAR T, allogeneic transplant. So how do you sequence all this?
Okay, so let me take you through a patient case, actually. So there's a 36-year-old man who had Ph negative B cell ALL, and he received the standard AYA protocol with a CLGB 10403, so asparaginase based protocol. At the time, let's say this was pre blinatumomab, so didn't get blinatumomab during his consolidation. And then he goes on to some maintenance, but unfortunately relapses, and then gets at that time can get blinatumomab because he hasn't seen it before. And with that, you also have to make sure you have your CD19 expression, and then goes on to allotransplant. And then unfortunately, if he relapses after allotransplant, and as long as you're still expressing the CD19, then this patient went on to receive CAR T cell therapy. And so, from that standpoint, I think that's probably kind of a standard situation. But I think now the debate is, should we give that CAR T cell product before transplant to maybe avoid transplant? And so, when a patient relapses, I think we are now at a wealth of options. And so, from that standpoint, it's a conversation about risks and benefits of each of the different treatment options, and talking about what the short-term plan is to get somebody into remission, and then what a longer-term plan is to get them into remission. So I think it's the conversation about what treatment they've had in the past and what is likely to be effective now to put them in remission, but also sustain remission. And then age is a factor in terms of being able to tolerate the treatment. So it's a really interesting situation that we're in, and a good one to be in, because now we have so many more options than we did before. And I think it is good to consider whether or not we should be giving these patients CAR T cells earlier than we otherwise would have historically.
So along those lines, what are you excited about in terms of new and emerging treatments in adult ALL?
Yeah, so I think I alluded to this in the beginning, in that, are we moving towards an era where we're chemotherapy free? And so there are some interesting clinical trials, so nothing approved yet, but that look at the combination and the sequencing of inotuzumab as a single agent followed by blinatumomab without any chemotherapy. And so far, the response rates are promising and it seems to have some durability. Now, I think we do need longer term follow up, but it is a way to avoid the toxicity of traditional chemotherapy and not have to deal with the long term side effects that entails. Do I think that will ultimately end up being like, I'm cautiously optimistic that we're going to get to that. However, I still at this point think that there is a role for some chemotherapy. I think that we don't need the high doses of chemotherapy that we used in the past, but I think minimal doses of chemotherapy in combination with our immunotherapy will provide great or effective response rates and durable remissions. And that's because the reason why I think having just a sprinkle of chemotherapy in there somewhere is because you're then attacking the leukemia from multiple angles. And we know historically that chemotherapy is effective. I just don't think that we need the doses that we have used in the past. And so if you're using both a little bit of chemotherapy and then the immunotherapy, you're then able to maximize your efficacy.
So I'll tell you what I'm looking forward to is that hopefully, if I'm still interviewing in 10 years, let's do this again and we'll see if this prediction is correct. That would be
Yeah,
terrific.
right.
Some of the hard work that we do as oncologists, whether it be blood cancers or solid tumors, is reaching that stage with patients where we can't fix it, where all these options have been looked at or used. And I'm interested, even after a lot of years of practice, in doing that as well as possible. So let me ask you, what is your conversation like with patients? Again, you started this journey saying, well, where our goal is to cure this, and then you may reach the point you can't. I'd love to hear how you work through that conversation.
Yeah, that's a really tough one. So I bring up two kind of big things. One is I think that it's not fair to offer, in most cases, when there isn't a clear path forward, to offer somebody multiple treatment options that aren't going to work. Because when a patient is given the choice of whether or not to do treatment or not, nobody wants to die, right? And so they feel the need that they have to pick a treatment option because that's what our culture, what we're expected to do. And so there is always another treatment option, but the toxicity cost and the quality of life cost is a real factor. So instead of presenting treatment options, I ask about treatment goals and quality of life goals and what do they want to do. I'll give you just two extreme examples. Is that one patient who at all costs wants to stay out of the hospital, and the other patient who at all costs wants to stay in the hospital. And it's not very common that we have this situation, but some patients will say, I would rather die on a ventilator knowing that I tried, even if it means I can't interact with my family, because that's just, I want to know that I did everything possible. Most patients are somewhere in between. So if a patient can tell me how they want to live their life, then we can talk about the options that will help them reach that point. What underlines a lot of this is anxiety. And so then I talk a lot about what we have control over and what we don't have control over. And
Mm.
so when we're at a situation where we're at the end, we don't have control over the disease and the pace of the disease and how aggressive it is, but we do have control over the decisions we make to control the symptoms and how we move forward. And so I think about it in that sense of like, well, we're at a point where treatment isn't going to work, but you have control over how you want to live your life. However many, is it days, is it weeks, is it months? Do you want it in the hospital? Again, it gets to that whole point of how do you see yourself living day to day? And then we make decisions that help them feel empowered and control of the situation that they don't have control over.
Yeah. So I have to say, firstly, thank you, and beautifully said, because this is the art of medicine. And it's something I think we learn from mentors sometimes, and sometimes we don't. And then later in practice, not as often learn it from each other. So thank you.
You're welcome.
Let me ask you about MRD. How is it measured? I'd love to know more about the technology involved and what do you do with it?
Yeah, so MRD is a great topic because it has really evolved in terms of technique over the years. And I would say in ALL, it's pioneered the way. I'd like to say that I hope that we get this technology in our AML patients. And so, from a measurable residual disease standpoint, which we define as patients who are in complete remission, which is less than 5% blast, but measurable residual disease is anything less than 5%, but greater than zero. And that could be to a decimal point. And so, when we think about our MRD testing, there's flow cytometry, and then there's something called a clonoSEQ assay. It's a DNA NGS based assay where you are taking, it's really interesting because you're taking a patient's essentially barcode for their specific leukemia. And so you're testing the original sample for that barcode. And then subsequent samples in bone marrow or in peripheral blood, you can then test for that specific barcode to see how many cells per million are present in terms of measurable residual disease. Flow cytometry is probably the original MRD test, and that specifically is looking at a subset of the different, I call them color-coded flags that sit on the surface. But there's different ways to do it, whether or not you're just comparing it to normal versus comparing it to the patient's previous leukemia-associated immunophenotype. So there are some kind of nuances to that. And then for the patients who are Philadelphia positive, we can follow their PCR if they're P190 versus P210 and be able to quantify how much. And MRD is particularly important in relation to allogeneic stem cell transplant because we know the patients who are MRD positive going into transplant tend to have a worse outcome. And so we prefer patients to be MRD negative going into transplant. And now that we have such sensitive techniques to determine it, it has been really helpful in terms of getting these patients to transplant and having that discussion.
Okay. So let's take a patient where they're MRD negative, and then vice versa, a patient who's MRD positive. How successful is allogeneic transplant in both of those scenarios in terms of clearing the MRD? And what impact does that have on survival, whether you, again, clear it or don't clear it? I suspect it would be a major one.
Yeah. And so I guess if we speak in general, because transplant is an effective way to potentially cure a patient if transplant is indicated. However, now that we have newer therapies, we might not need transplant. So, what I would say is, for example, for the pH negative patients who are responding appropriately, they don't need transplant. However, if they are still MRD positive after consolidation, then we often want those patients to go to transplant. And so then if that's by chemo, then maybe we're adding a blinatumomab or some other therapy to get them MRD negative to then take them onto transplant. For the pH positive patients, I think that's where that debate is really changed in terms of we used to think that all of the pH positive B-cell ALL patients should go to transplant. And now with the combination of blinatumomab plus TKI, that is up for debate. So I think more to come on that. And then for the T-cell ALL patients, it's also really dependent on how they're responding to treatment and if they become MRD positive or negative and hitting certain time points. So I would say transplant is still an important role and still will continue to be an important role, but it is much more complicated in terms of who should go to transplant.
What are some good resources for oncologists and other healthcare professionals in our field?
Yeah, so for oncologists, I would say NCCN is a really great resource and has improved under the heme malignancy umbrella really over the last decade, where I feel like previously it was more from a solid tumor standpoint. The other really great resource, I think, for both healthcares and for patients is obviously the Leukemia and Lymphoma Society, just because the information is vetted by people who are in the field. And there's also a lot of resources for patients specifically in terms of being able to have different outreach or access to information on clinical trials. From that standpoint, the Leukemia and Lymphoma Society recently has been hosting what I call Philadelphia leukemia rounds. So this is something that we meet twice a year in May and October, where we bring together healthcare professionals, both in an academic and community practices, both who are physicians but can also be APPs and nurses and pharmacists. And we do case-based discussions and have really interesting discussions. And LLS is now also extending that into other cities. And so those I think are really great just because you get the one-on-one personal connection of being able to discuss a case with a colleague. And that, might lead to a referral or other cases that are discussed amongst colleagues and amongst peers.
We need to do that in Baltimore. Anyways, that's great. This has been terrific. Again, this is Dr. Ken Miller. I want to say this has been a great, great episode. And I want to thank Dr. Catherine Katie Lai, who's an associate professor and the leader of the Leukemia Clinical Research Unit at University of Pennsylvania. Katie, thanks for being with us.
Yeah, thanks so much, Ken. I really appreciate it. And really thank you again to LLS for hosting this podcast.
I want to thank all of you for listening to this terrific episode and for a listing of all of our other healthcare professional continuing education activities, podcasts, and other healthcare professional resources. Please visit lls.org/CE. For any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families, and that can be found at lls.org/support. And I want to encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society. And access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.